Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. Today is a special Grand Rounds. We're going to be in conversation with Mark Larratt. Mark has led the UCSF health system for more than 20 years, I think 21, and he will be retiring at the end of next month. Having watched up close and personal, I can tell you that Mark has been an extraordinary leader who has not only transformed the healthcare system, UCSF Health, and grown it massively, but he's also been a national thought leader in issues that relate to healthcare delivery generally, and particularly academic medicine. There are lots of metrics of growth. One particularly striking one is when Mark arrived, the UCSF Health's yearly revenues were $600 million, and this year they're about $6 billion, so 10x over the course of 20 years. In the next hour, we'll talk about his career, the transformation of UCSF under his tenure. We'll talk a little bit about COVID and where he thinks the world is going as he hands the reins off. If you'd like CME, stay on until we're done, and there'll be instructions for that. The usual instructions are here for all of you. If you have questions, type them in the Q&A box. I think I have close to an hour worth of things I'd love to hear from Mark, but we'll go ahead and my colleague Lakshmi Santosh will mine the questions, and if there are others that come in, she will pitch them to me. The session will be recorded and posted in the next couple of days on YouTube. So with that, Mark, if you could come on, that would be great. Welcome.
Welcome. Thank you. Glad to be here.
Great pleasure to have you. I was at a meeting with Mark this morning where he feigned laryngitis, but apparently his voice is just fine. So good. Let's go ahead and get started. Why don't you start by telling us a little about your upbringing?
Well, Bob, I was the child of a state park ranger. So I had two brothers. We lived all over California, mostly in very rural areas. I grew up in grade school where there were fewer white kids than there were Washoe or Paiute kids. Moved down to the Central Coast, went to high school for a few years there, finished high school in San Diego, and then off to UCLA, the big city, for my college education. And from there, things took off.
And what gave you the inkling that you wanted, first of all, to be a leader? Were you a leader type growing up? Were you the head of your Boy Scout troop or any of that? And then also, what got you interested in healthcare?
You know, I was a capable student, a very capable student, and I think I always felt like I wanted to be in as big a pond as I could possibly be in. And you know, when you start out with 2 grades, 2 room schools, you know, that's not really the big pond. So that's why I wanted to go to a place like UCLA. You know, I had no idea in college or before about what I wanted to do with my career. In fact, I thought I would be visited with some vision at some point of what I wanted to do, but I dutifully did my political science major at UCLA, applied to grad school, started working for a market research company in downtown Los Angeles. And it was then in 1980 that there was an opening for a director of communications for the Center for Health Enhancement at UCLA. This was an early preventive medicine program. Jonathan Fielding, Chuck Kleeman had started it, and I took that job on. I thought, well, maybe I'll come here for a couple of years, put UCLA Medical Center on my resume, and go get a real job. But I fell in love with it. And as many people who are not clinicians and weren't visited with that vision that this is what they want to do, you get into these environments and you start working with people who are committed to helping others. You see the difference that you make in people's lives, even if you're a non-clinician. And I was hooked. So the rest was history for me.
Great. I'm going to fast forward through a lot of your history to the time you arrived at UCSF. So you got here, you had been the CEO of Irvine. You got here at a time that the place was in terrible trouble. We had merged, we had left the University of California as a health system, merged with Stanford to create a standalone UCSF Stanford Healthcare. It had imploded. We were run by consultants for a couple of years. People were very unhappy. First of all, what convinced you that this would be a good job? And then second of all, when you came, how did some smoldering ruins?
Well, when I was at UCLA, I spent 15 years there in all, and I had done a lot of work with the regents on various issues, led the acquisition of the Santa Monica Hospital. We were always doing something with Medi-Cal of one sort or another. And I got to know these systems reasonably well. And then UC Irvine, when the position became open there, was in some degree of extremis itself. It had gone through the Center for Reproductive Health scandal. A couple of doctors had fled the country, that they fired the management and so forth. And I'm not sure that I would have hired me, but Chancellor Laurel Wilkening and Executive Vice Chancellor Sid Golub, who I'd known at UCLA, did. And that's when I really came to appreciate that the most important thing in leadership is leading with values, doing the right thing, treating people with respect, setting out a clear vision that you can defend to anybody. And when organizations go sideways, it's because they get focused on the wrong things or get distracted from the right things. So the wrong things are often trying to make more money or be more profitable or one thing or another. So my experience at Irvine was a great awakening for me. It was the difference of being the number two person in an organization. Number one is it's I don't know, it's a quantum leap, because suddenly you have no real friends. Your opinion matters more than it really should. But I adapted to that at Irvine. And then when the UCSF Stanford merger was falling apart, I'd been asked by one of the regents if I would consider it. And I can tell you at UCLA, they have a very high self-image at UCLA. But in their hearts at UCLA, then and now, they know that the best healthcare system in the UC system is UCSF. I knew that from Irvine. And so at UCSF, the strength of the faculty, the tradition of exceptional research, being at the forefront in tertiary care, those are the fundamentals that very few other organizations have. So I jumped at the chance when I got it.
And when you jump into a little bit of a fire and you know that the place has been struggling and has gone through a traumatic period, I imagine starting a new job is very different than if the place is doing great. So, I mean, you're going to hand this off to someone soon, and the place is doing great by and large. It's obviously there are problems and issues but certainly financially doing fine and on many dimensions. So how did you think about sort of what do you do in the first couple of months as you step into a place where there's really a set of problems that have to be addressed quickly?
Yeah, I think the first thing you do is use your ears and mouth proportionately, as God gave us two of one and one of the other. And so you just listen. And I listened to the faculty, to the staff. There was a lot of dissatisfaction. But you also very quickly come back to what are your organizing principles here. So that's when we developed our mission statement: caring, healing, teaching, discovering. Spent a fair amount of time on that. That's when we developed this vision to be the best provider of healthcare, best place to work, best environment for teaching and research. And that's when we developed our pride values. And you start with that, and then get people together to do what we would call now a strategic plan. Where are we going? The thing that was most obvious to me, aside from the smoldering issues, we were losing over $1 million a week. Our payroll was being handled at Stanford. We were doing their medical staff work. It was just a mess. We were getting shut off from medical gases because we hadn't paid our bills, all that kind of stuff. But what you want to do is to get people to think about where can we be in a few years? What are some steps we can take? And so one of the obvious issues we had at UCSF is we were small. our average daily census was under 400. And one of the things you learn about these healthcare institutions is that they're high dollar, low margin businesses. So this was probably what got UCSF Stanford into trouble. Whatever their revenue was, a couple of $1 billion, but the margin was going to be 1 or 2%. So when you're losing money, it seems disastrous. But if you can just tweak efficiency a little bit, tweak revenue a little bit, tweak your sponsor mix a little bit, you can go to start making some money. And once you start making money, it allows you to invest in your clinical programs, your academic programs, your public service mission, all those things. And we just knew we had to get bigger in order to do that. So we developed a strategic plan, and with the chairs, we pretty much executed on it. And it was one of several plans that we've been on over the last several years that allowed us to grow. And in that growth, allow us to be financially stronger and put ourselves in position to build new facilities and modernize our equipment and so forth.
Were there advantages coming into a place that had been in crisis in terms of the freedom that you had to do some hard things?
Yeah, I think there are advantages, and particularly for someone like me, it's very possible a place like UCSF, had it been very successful, wouldn't have brought in someone who'd had my background, a non-clinician, into this kind of a role. But I tell people that the most important thing in these jobs is leadership capabilities, and your academic credentials can be really important too, but you have to be able to lead. So in my circumstance, it was maybe it was easier because we started we went down to bare stone and built it up from there. But there are certainly times when along that way that we thought we coveted those organizations that had the big balance sheets and were looking at making big investments and so forth, and we were just trying to make payroll.
Yeah.
So there's some advantages, but there's disadvantages as well.
You'd be happy not to be in that position too.
Yeah, I'm glad to not be there now. Exactly. Once was
you brought up I think an important tension as I watch you do your job, which is sort of the money mission tension. And you've talked about the importance of the mission and the values, but you're also running a now $6 billion a year not-for-profit business that has to make a profit. It doesn't work unless there's money to do things with. And there are certain things that we do that are very profitable, surgeries and transplants, and certain things that we do that are less profitable, taking care of patients with no insurance or Medi-Cal, many of the geriatrics, primary care, infectious disease, you can list them, but are a really important part of our mission. So it feels like getting that balance right is a daily struggle. And, I probably, there's analogs to it in other businesses, but it feels sort of more acute and more real in the healthcare delivery business. So how do you think about that struggle? And as you said, these organizations that go sideways, it's often because they were focusing too much on the dollar.
Yeah, well, they can focus too much on the dollar or not focus enough on the dollar and go sideways. Either one can be a real challenge. I think this is the fundamental challenge of running these kind of organizations. But when I was a young hospital administrator at UCLA, I was about to get the pager to be the administrator on call for my first weekend and first week of nights. And the grizzled veteran chief operating officer, Aaron Lohr, said to me, "You're going to get calls and you are not going to know what to do." He said, "But let me just tell you this. Always do it as in the best interest of the patient. Big research program going on, but the patient needs something, do what the patient needs. Big financial issue, but the patient needs something, get the patient what the patient needs. We'll sort out things afterwards." So I tell that to new employees. I still do every new employee orientation. And it is, I think, kind of a guiding principle for how to think about our job. The point you made is absolutely true. We make most of our margin on a small subset of the patients we serve. We lose a large amount of money on most of the patients we serve. We make money on commercial patients. We lose money on Medicare and Medi-Cal patients. And my attitude has been that I don't really care as long as in aggregate we can make enough of a margin to support our academic mission, our public service mission, that we can make the appropriate investments in our facilities and equipment to keep us at the forefront. That's what our main job is. Oftentimes we've had advisors come in and say, gee, you're making all your money over on these surgical programs. Why don't you get rid of pediatrics or, do something else? And that's just not who we are. Not who we are as a training institution. We need to have the full complement of trainees and services here, not who we are from a research standpoint, and not who we are as a clinical organization either. We need to be carrying more than our fair share of responsibility for making sure that everyone gets the health care they need. So we're fortunate in that we have been able to generate the margins. We've had enough of those high margin cases and high margin commercially insured patients to make up for the losses. But to me, I don't want our faculty or staff feeling like they're working in the profitable or the unprofitable part of the organization. That accomplishes absolutely nothing. We're part of one integrated organization here. And in aggregate, we make enough money to make this whole thing work. And that's the magic of these academic medical centers.
Thank you. I think there was a CMO a long time ago who was a surgeon who once said to me, Bob, a medicine patient is only slightly better than an empty bed. And I was sort of, okay, now I know my place in the world. I appreciate you saying that. Another source of revenue is philanthropy. And we and you have done very well, obviously with certain natural advantages by virtue of being in the Bay Area, but probably a reasonably large part of your job that I'm sure most people don't understand. So how do you do it? Do you like it? Does it cause you to stay up at night? How does all that part of the job work?
Bob, I had really done nothing on philanthropy until we faced our Mission Bay Hospital project. And that's when we had the reality that the project was going to cost $1.7 billion. We could borrow $600-700 million. We had a little bit of cash, and we were going to have to raise $600 million to make it work. And I thought, my God, how is that ever going to happen? And we had some very generous early donors who made gifts to kind of get the ball rolling. But one of the people that's been most instrumental in helping UCSF is someone many people may not know, and that's the founder of Duty Free Shops, Chuck Feeney. He didn't actually technically founded it, but he made it a worldwide business. And his goal was, with his many billions, is to give it all away during his lifetime, which he has done. He's still alive, lives down in the Mission Bay area. And Chuck Feeney said to me when we were talking about this hospital project, and he'd already given some money to UCSF. He'd given money in Australia. He'd given money in Vietnam. He helped pass legislation in Vietnam requiring motorcycle helmets because it was the leading cause of death in Vietnam, and then paid for motorcycle helmets for everyone in Vietnam. I mean, this is the kind of transformational philanthropy that he supported. And he said to me, Mark, people don't give in proportion to your need. They give in proportion to your vision. And that just rang with me forever, that the bigger the vision, the more dollars that it attracts. And with that, we were able to secure the support of the Benioffs, who are incredibly generous, a big vision of what we could do with children's health. And then we added the Mission Bay Hospital or the Benioff Children's Hospital, Oakland, into that mix later. But I think that's the lesson I take from it. I think Sam Hawgood has been extraordinarily successful as a fundraiser for UCSF. Many people thought he's not the swashbuckling guy that comes into a room and everybody goes, "Oh my gosh, pull out your checkbook. We're going to end up giving it to Sam." But by virtue of the case that he makes about the quality of what's going on here, the success that we've had, people want to give to a winner. And so we start planning for a new hospital at Parnassus Heights with a $500 million gift from the Helen Diller Family Foundation. That's stunning. And by the way, that's the second $500 million gift that incredibly generous family has made to UCSF. So yes, we are, as I tell people, our fishing boat is over some big tuna in our waters where there's a lot of wealth in our community. But I think it's much more than that. It's really that we have a vision for success, a vision for how we can transform the health and well-being of all Americans, all people around the world, and people buy into that and want to support it. So I think philanthropy becomes everyone's responsibility. And again, I always go back to just make sure you're focusing on the vision, because that is what draws people in.
Yeah, and then the values too. I think it's sort of, why are people here? What are they trying to accomplish? And that's part of what attracts people to be part of it. That's great. There's another tension of running a place like this that your colleagues that run community hospitals, even big ones, don't have, which is balancing the academic missions. And a dollar in a community hospital or a non-teaching hospital is going to be spent, if you have it, on improving care and improving your access and all that. A dollar here could be spent on that and could be spent on research and education. So being in the middle of many of these conversations with you, I know it's a constant tension. Sometimes we're on different sides of the table on that. So how do you think that one through to get that balance right?
Well, whenever this discussion comes up, and I've lived through it my whole career, and I've seen people lose jobs over fighting these battles. Who's right? But what I try to emphasize to my team is that the reason that the health system is successful is because of the academic success of UCSF. So when there's a Nobel Prize that's won in the basic sciences by David Julius is not seeing patients, but his success brings a credibility to UCSF that makes a difference in our ability to be successful. So the clinical and academic missions are completely symbiotic, and we need to treat them as such. Now, that doesn't mean that there aren't going to be arguments over where that next dollar ought to go and what is the highest and best use of that dollar. And that's where we have our discussions. But I think if everyone starts with the mindset that we succeed together or we will fail individually, that's the key. I'm just reminded that probably 15 years ago, state support was probably two-thirds to UCSF was probably two-thirds higher than it is now, maybe double what it is now. And now it's dropped so much, and that state support goes to support the academic mission. What has made up the delta has been some philanthropy, but mostly clinical dollars. And I think that's just fantastic. My only anxiety as I look toward the future is that in the old days, when the hospital would get into financial trouble, a la the UCSF Stanford era, the hospital got into trouble, everybody was concerned about it, but it was the hospital's problem. Now we have so much riding on the back of clinical income, our education, our research programs, so much of the infrastructure of the university, we almost can't afford a major hiccup in clinical income. So this is the thing I worry most about is making sure that those dollars are going to keep coming, and that we're always careful about not putting more and more, maybe it's the holidays, I'll say ornaments on the Christmas tree such that the tree becomes too heavy, or if there's a policy change and revenue drops, that it hurts the academic program. So it all fits in together, but it's an area that we have to be very careful about long term.
Great. You mentioned the UC system, and you told me there were no questions that are off limits. So let's go. We are part of the University of California system. It probably brings some significant advantages. But as you mentioned, one of the advantages used to be a fair amount of funding that came from the state to the university, and less of that comes now, I think, because they recognize that there are other sources of revenue that we have. I doubt that they have dialed down the level of oversight or bureaucracy commensurate with the decrease in funding. So what is your job like in terms of dealing with the UC system as compared to a colleague who isn't part of a state system?
Yeah, I think it's a mixed bag, Bob. In some ways, you're absolutely right that as state support has dropped, there's an inverse relationship with the amount of oversight and meddling and so forth, which probably every organization that's part of a big central operation feels that anytime central gets involved, it's meddling, and the central always feels like they're keeping things organized. So I don't know what's right there, but I do think there's this tension between what's in the best interest of an individual campus versus what's in the best interest of the system as a whole. And we continue to have issues and challenges. My personal feeling has been that we probably should think about more linkages and more integration across the UC health systems than we've had in the past. There's an argument that regents love that we should have our own health plan covering the entire state. There are some regents who say, why do we have organ transplant programs at UC Davis and at UCSF? Shouldn't we concentrate them at one site? And there's arguments on all these issues. But I do think that over time, there will be more and more pressure to become more efficient and to streamline the administrative costs and presumably find a way that we can work more efficiently together. So I expect that over time, there'll be a closer relationship. But having said that, the reality at UCSF is the health system accounts for about 60%, almost 2/3 of the total budget of the university, UCSF. And at UC system-wide, it's right around closing in on 50% of the entire University of California operating budget. So it's a big deal. And I think that the regents and leadership, the Office of the President, recognize that and want to make sure that it's being managed well to the benefit of the entire university. There are some who argue this is the tail wagging the dog. This is technically an auxiliary enterprise, auxiliary to our core missions of education and research. But increasingly across the state, people view what we do in the University of California as absolutely essential to the healthcare system in this state, which I completely agree with. So it's going to be always a tension between what we want locally and the pressures coming down from central headquarters.
And in terms of the way money flows, you talked about one of the challenges is you make $1 and we support the academic mission, education and of residents and medical students. We support research and labs and clinical research. Are we also being called upon to support the English department at Santa Cruz? Is that part of what has to happen given that substantial flow of money that comes from the health systems?
Well, I don't think so. Certainly not directly. But what we are being called upon to do is to support the central UC health infrastructure. And we we pay a tax on clinical income to UC centrally that helps the central operation of all the support services from legal and communications and lobbying and all the other things that go on there. But you put your finger on an important issue, Bob, that is one of the reasons why chancellors, and I'll exclude UCSF from this because we're health sciences only, but general campus chancellors love having control of their medical centers because it is really, when you think about it, clinical income is one of the few sources of fungible dollars. State dollars are usually tied to something. Philanthropy is usually tied to something. There's really not much else. I mean,
Well,
grant
it's got to be,
funding.
it's clinical revenue in the football team. It's probably, that's it.
And I don't think any of our football teams are contributing anything positive.
Right.
So this is why they like having that. So there is a way to spread overhead around on the campuses. So this is it's an important issue.
Yeah. All right, I want to turn to sort of a set of big issues that you've dealt with and just see what your thoughts and reflections are on them, how the organization responded, how you responded to them. Let's start with COVID, front and center. When you first heard about COVID, whether it was in China or seeing what was happening in Italy, I imagine you said, big deal, this is going to transform this place, we got to deal with it. Sort of what was your reaction, and then how do you think we've done over the last year and a half?
Well, my reaction was I hoped that this was ephemeral, that wasn't going to be part of our lives, but it pretty clearly wasn't. But I'll say, Bob, that when the first COVID patients in the Bay Area were identified in the South Bay, there were at least 2 hospitals who declined to take them, and UCSF said, we will gladly take them. We had staff, this is before people fully understood the implications of what COVID was or wasn't, or what the risks, transmission, any of that stuff. We had staff who said, I volunteer to work in that unit. And our faculty jumped right in, reminiscent in a way of how UCSF faculty and staff, the general, stood up during the AIDS crisis. It was so touching. So, and then that was shortly thereafter followed by the crisis in New York City, and our teams saying to Chancellor Hawgood and Dean King and me, can't we go back there and serve? And can't we go back and serve the people in the Navajo Nation, which we fully supported. We weren't being terribly affected by COVID. And they learned a lot, they contributed a lot. And one of the things I'm just so incredibly proud of the service orientation of people in this organization, want to go out and help others at their time of need. And then we started to have our own needs. And as you know, the volume grew and so forth. But throughout it all, our organization has stood tall. And I think we often talked about this in some of those early town halls that, if not us, who? We need to be the ones to stand up and take leadership. So we hosted calls every other week for hospitals and physician groups in the Bay Area to get the latest on what was known about COVID. And because we had been so generously helped by the Salesforce.com team, we had plenty of PPE when others couldn't get anything. And we were shipping PPE out all over this state in this country to other organizations at no charge. We just did it because it was a crisis. And again, I think that's who UCSF is and should be, that kind of leader. So to this day, I guess that's my attitude, Bob. I don't, I listen to you. I listen to everybody who talks about COVID. I don't know where it goes. I'd hoped it would be in our rearview mirror at this point. It clearly isn't. But the one abiding truth through all this is that we've stood tall. We've done what we needed to do. We needed to start video visits. We did. So I just have nothing but gratitude and respect for the people of this organization at a time of this crisis. I'll just put a footnote on it though, Bob, and that is that COVID's taken a toll on our people. When a lot of people, including myself, were able to work from home because I was on a Zoom all day long. We had thousands of people who were in every day. Transportation wasn't easy. They had childcare issues because schools weren't open and you couldn't get childcare. They had a spouse who'd lost a job. This has been an extraordinarily challenging time for our people. And I know we say it, I don't know how far that goes, but I know I joined Chancellor Hoggood, Dean King, all the leadership of UCSF and saying a profound thank you and trying to do everything we can to take some of that pain away going forward. We're going to take a long time to recover from this. But in the heat of the crisis, we were there 24/7. And I have nothing but respect and gratitude for the people who were there at the front line.
Great, thanks. Another issue, digital transformation. When you arrived at UCSF, we were writing in paper charts and on 3-ring binders and fax machines and Post-it notes. And now we have an electronic health record and patients are on it all day, doing a lot of digital innovation. So what's your take on where we are and what the roadmap is for the next 10 years or so?
Well, I'm glad you asked it that way, Bob, because the way you could have asked it is, what took us so long to get into the modern era?
Yeah, I'm much nicer than that. You should know that by now.
When I first came, I was looking back, I've been going through some of my old papers, and I had given some remarks in 2001 and said within 3 years I want us to be on an electronic medical record system. And we unfortunately were on one of those systems that didn't make it. As I tell people, it was like we were sitting on top of a dead horse and kicking it, urging it to move forward, but it wasn't moving. And finally, after some legal wranglings and so forth, we were able to get ourselves onto Epic, and I think things move forward then. So we were slower than I would have liked in this space. But I think, as you well know, Bob, the landscape of digital transformation is changing very rapidly. At one time, it was, can you get your meds online, or can you see, can you send a note to your doctor and ask about a follow-up visit or something along those lines. But now the expectations of society have really changed, and people expect same day or instantaneous service. Several of us went back to the Cleveland Clinic just a couple of years ago before Toby Cosgrove stepped down, and listened to them in one of their sessions talk about same day appointments. And they settled on this concept of same day solution, that if somebody calls before noon, we're going to have some solution for them. They want to be seen in neurology where maybe the end is needless. At least we can get their medical records. Maybe we can set up an appointment. Maybe we have an APP talk with them. Maybe we do something, but we don't just say, send in your records, we'll get back to you in 8 weeks and we'll see if we'll accept you as a patient, which is frankly how we have operated in many of our subspecialty clinics. I think that mindset has really put a pressure on us and all other organizations. So years ago, when we did our first effort at digital transformation, it was to get the text number of a patient and text the patient and say, please call between 8 and 5 at this number to make an appointment. Well, that was a step, but it was not the step that people wanted. They wanted to be able to go online right then and actually book an appointment. And we're now starting to do this in the cancer center. We're doing it with breast surgery at the Berkeley Outpatient Center. So my hope is that this will be the next big transformation for us, is much more patient-driven interaction with the system. And what we found is that a lot of the fears that our faculty had, that they would be inundated with inappropriate patients, that really hasn't happened. That we've been able to, if that we see that that's forming up as we're collecting the information before the appointment, we're able to get patients redirected. So I think we're all learning here, but we have to respond to society's expectations of us in a more real way, and that means real-time changes in how we deliver care, but also how we schedule care.
Yeah, I would say though that one of the fears that the faculty have had is that we will turn on the switch for 24/7, 365 access through an electronic portal, and we will be flooded by messages that just I'm going to be doing at 11 o'clock at night, and that has happened.
Yeah.
So, and I'd say it's probably complaint 1 through 5 among faculty, particularly those who do ambulatory care. How do you think about that?
I think that's absolutely right. That is a huge problem. The work lifestyle has become untenable for many of our caregivers. I think this expectation has been created by the One Medicals and others who've done an extraordinary job, where at 1 a.m. you can go online and say, I've got, you get a doctor to look at this bump that you've got on your leg to see if it's worth worrying about or not. And that kind of service is available there. I think we have to be very selective about where we play in this. We're not really designed for urgent care that much. We're much more down that tertiary, secondary, the late secondary, tertiary, quaternary road. And I think that we're going to have to be very thoughtful about how we protect our faculty there. Maybe what we have to do is to build relationships with urgent care and others in the secondary care areas, which we've done to some extent in areas like cardiology and others where we have large numbers of caregivers who can provide those kind of services. But this is going to take some careful management over the years.
Yeah. As you mentioned, if I was nastier, the question about digital would have been why did it take so long? I will ask that on the network, that we were pretty late to the dance in terms of forming a large, far-flung network of partners in the region. We were really, for a long time, a few buildings in San Francisco. Do you think we were late? And maybe that was a strategic choice. Maybe other places needed to do that and we didn't. But obviously we're doing it a big way now. So how do you think about that? How do you think about the timing, and what excites you and what scares you about that whole process?
Yeah, I don't know. Maybe we were late. I'm not sure that others who were much earlier than us in this market had a lot of success, but we really started in earnest in 2013 was when we convened a group of the non-aligned hospitals in the region, physician groups in the region, and said, what should we be doing, if anything, together? And I think it had kind of taken that long for many of the independent hospitals in the region to come to the realization that their market share was being eroded by Kaiser. And what they were being asked to do was the care that Kaiser wouldn't do, which is, some of the lower income indigent care, and that they were starting to struggle financially. And at about that era, that's when hospitals started to say, we need a different approach, a different partner. And they weren't going to sell to the Sutter system or join the Dignity system or Kaiser. Kaiser wasn't interested. But that's when we, as much as anything, and maybe this was the critical factors, we changed our mindset. When I grew up in healthcare and academic medicine, the goal always was get physicians in private practice in the community to refer tertiary patients to us. We'll do our thing, and then we'll return that patient. Mostly we'll do it because a lot of times the patient didn't want to go back, but we'll return that patient back to you. And we finally came to the realization, first of all, we were pretty full at UCSF, that we would do better to actually bring our services to the community and let them stay there and then only bring back to UCSF those specialty cases that really only needed to be here. One of the first places we tried this was at Washington Hospital in Fremont, where, well, their first initiative was they wanted to run their own NICU. They wanted us to staff it, but they would transfer babies to us when needed. And that worked out pretty well. And then the next thing was in cancer. And we, through Jeff Wolf and others who've done an extraordinary job, hired oncologist, UCSF oncologist at Fremont, at Washington Hospital in Fremont, taking care of patients there, but when those patients needed the more advanced levels of care at UCSF, bringing those patients here. And that model really took off and resonated with hospitals in the region. So today we have relationships all over the Bay Area, from Sonoma to Community Hospital, Monterey Peninsula, every place in between. And each one of them a little bit customized, as you know, to meet the needs of the local community. To me, the best part of it is that it has given UCSF a steady base of referrals to ensure our financial well-being long-term that we did not have before. And it's created partnerships where I think we can improve the quality of healthcare and access in the community in a way that we hadn't done before. The downside is that these regional networks are a bear to manage, with different expectations of our faculty. Sometimes our faculty are overseeing what's going on in the community. Sometimes they're just hearing about it, which makes them nervous. So we're still finding our way, and you as co-chair of our strategy committee at UCSF Health are right in the center of it, and I have every confidence that you'll find a path forward that works optimally for UCSF and our partners, and most importantly, the patients that we serve.
Trying, yeah, it's tricky. It is very tricky. One particular one, and again, you told me nothing was off limits. One particular one that was challenging was dignity. How did that go, and could that have gone differently than the way it played out?
Yeah, it was a very stressful discussion, and the way this originated is that the two San Francisco Dignity Hospitals, St. Mary's and St. Francis, had a lot of empty beds. We had huge demand. We didn't have empty beds. We wanted to move some services there, and then some very well-intended, values-driven members of our faculty and the community pointed out that there was a real conflict with our values at UCSF and some of the Catholic directives around limitations on women's reproductive rights and end-of-life issues, and their treatment of others, some in the LGBTQ community, which we all shared those views. But that set of discussions was created an enormous amount of tension within the University of California health system across the state, because there were people who certainly supported that we should have nothing to do with organizations that have these values. But what became, I think, the more compelling argument was that the University of California needs to put the interest of patients first. And so as much as we don't endorse the Catholic restrictions on healthcare, we were not going to pull medical residents from UCSD out of Father Joe's homeless clinic to make that point. That we would be penalizing those homeless patients who have no other choice. It's not like there's another group of providers willing to step in and take care of them. And I think that story across the state, where people were born in a community where the only hospital serving them was a Catholic hospital, case at UC Merced, that's a Catholic hospital there. that we should not be boycotting those hospitals. And that's where the regents ultimately came down. I think one of the best outcomes of this, though, is that this discussion caused us to go back and take a look at our contracts. We had some language that was really completely inappropriate that we took out of those contracts, saying that we would enforce the values and so forth of the Catholic guiding principles. And so I think we've made big progress there, and I think Catholic healthcare has had a big awakening as a result of this discussion. So all in all, I think a positive outcome. A lot of stress, but a good gut check on what are our values really, and how do we think about them.
Yeah. So we're coming up toward the end. One other values question I want you to sort of help reflect on is the issues of equity and racial justice are front and center now, and it's always something that we thought about here, but certainly has taken on resonance in the last few years that feels different than it has for the prior couple of decades. So how are you processing it now? How do you think we're doing?
Bob, I wouldn't have put this on my top 10 worry list 10 years ago. But today it's number one. I think health inequities is the single biggest issue facing the healthcare system in this country. I think it's shameful that we're where we are. And it's well past time that we put energy into this, as we're starting to do at UCSF. One of the things that Josh Adler has led is our scorecard that looks at, a simple thing. What's our hypertension control among Black patients versus white patients versus Asian patients? And there was a difference, but we've narrowed that difference. Well, that effort needs to go on steroids in a huge way across the entire healthcare system. And I again personally feel like one of the driving, the true north driving forces for this organization as a national and international leader needs to be constantly putting this issue at the forefront. I mentioned earlier the work our people did in the Navajo Nation. And I will tell you, I was participating in weekly calls with the teams there. They're just horrified at how little investment in medical infrastructure there is in the Navajo Nation and in the Indian Health Service in general. Ancient buildings that had no ability to provide the kind of care that was needed by COVID patients there. How does that actually happen in our country? And congratulations to Shri and the team from HEAL who've taken this on. Again, something that makes me so proud about UCSF. But we need to really push on this in a way that we never did before. So thanks for bringing that up.
There are a few people who are asking the question, who is going to be your replacement? I don't think it's been announced, so you can announce it right here.
I think if I announce something that Chancellor Hoggood would fire me, and I've still got another month to go, so I don't want to do that. But I know Chancellor Hoggood's working on this, so that I expect something to be announced shortly.
This sounds like a job interviewee kind of question, but I'll ask it. As you reflect toward the end of your tenure, any regrets, anything that you wanted to accomplish that you don't think you did?
Yeah, it reminds me of that Frank Sinatra song, Regrets. I've had a few.
I've had a few, right?
What happens is that you look at the list of issues that you wanted to take care of that you didn't get done. One of the things that I regret is that we didn't do a better job in creating a career ladder for our employees. People who come here who don't know what options are available to them. Maybe they come in at the lowest rung of a labor-oriented position, and an organization our size and scale ought to be able to say, if you want to keep doing this job, great, we support you and we'll make it a great environment. But if you want to become a medical assistant, or you want to become a rad tech or a clinical lab scientist, or we'll help you go to community college. We'll give you the training. And we do some of that, but not nearly enough. So that's one of the things I put on my regret list.
And reflect a little bit on, you did this earlier, but sort of what you've learned about leadership. What's the thing you didn't understand about leadership that you've learned in your tenure here?
Well, I talked about values, so I won't go over that again. That is clearly the most important thing. One of the other things that was really pushed on me by a couple of staff members, and by the way, here's one of the things you learn in leadership. It's really hard to have people tell you the truth because people want to tell you what they think you want to hear. And the most important thing is to surround yourself with people who aren't afraid, and you need to make sure that they're not afraid to tell you what's really going on, because that's the most important thing. But people want to be led. They want to know that leadership has a vision and a direction and a plan to get there. And so part of the job is to make sure that you have it. I mean, you can't just act like you have it. You really need to have it. But then also to communicate it, and to communicate it with confidence. As in some of the most difficult times, and this was clearly true coming out of the merger with Stanford, people were really worried. Am I going to have a job? Are we going to survive this? Are we going to make it? And they're always looking at the leaders. What's their attitude? Are they conveying optimism and confidence, or are they nervous too? So those kinds of things I probably hadn't paid much attention to before, but they really are important. And I've become more and more confident about our future over time. But it's always important as a leader to communicate that. I'll say one other thing, Bob, that the best thing and worst thing about this job, the best thing is the people you get to work with, you help shape the agenda, all those things. I could go on and on. The worst thing about it is it's 24/7, it's unrelenting. And if there's something that didn't go right, you know whose fault it is. It's your own. Somebody told me when you point a finger at somebody else, there's three pointing back at you. And when our patient satisfaction isn't where it ought to be, who didn't set the tone and put that on the agenda? It's me. Or when people say, well, they should have done something. Well, who's they? It's me. So it is always there. And I relish it. It's been the privilege of my lifetime to be in this role. But it is one of the challenges that comes with being in this job, is that you never really feel like, you're never done. Yeah. But you're always pushing that next block
after 21 years, it feels like it's time to move to something else. So maybe the last minute, what is the something else? I've seen your golf game, so I'm hoping that's not it 7 days a week. So what do you plan to be doing?
Yeah, my golf game, the only way I can lower my score is to play fewer holes. It's terrible. No, Bob, this has been a moment of reflection for me to think about what I want to do next. I'll be 68 in January. I still feel like I have at least some good years, assuming UCSF primary care can keep me going. I'm on a few boards. I will go on a few more boards, everything from public policy. I just joined the board of Blue Cross Blue Shield of Arizona, so I'm learning about the health plan side, to some private equity startups. So it's an interesting time for me, but as I've said in every one of the interviews I've had for these board positions, what drives me is let's improve quality, improve safety, improve the patient experience, improve the provider experience, and lower cost. And if we can do that, we've done something extraordinary for the U.S. healthcare system.
Well, Mark, thank you for sharing your reflections with us, and truly thank you for your leadership and your inspiration. You have been spectacular, at the job. I've had the privilege of seeing it up close and personal in all sorts of ways. And it's, it's such a big organization. Not everybody has that privilege, and I know what you've done. It takes a new job. You really ask them, can you leave here for you? There's no question about it. So thank you.
Thank you, Bob.
everything you've
Thanks,
done for us.
everybody.
Appreciate it. Folks, if you're interested in CME credit, believe it or not, so, and we'll see you back again, I guess in a couple of weeks, Thanksgiving next week, and look forward to seeing you then. Thanks so much.